Good morning or afternoon, as the case may be. Welcome to the workshop, What to Do When Cancer Comes Back After Transplant or CAR T-Cell Therapy. My name is Steve Beekler, and I will be the moderator for this workshop. It's my pleasure to introduce today's speaker, Dr. Edmund Waller. Dr. Waller is a professor of medicine, pathology, and hematology oncology, and the medical director of the Hematopoietic Progenitor Cell Processing Laboratory at Emory University Hospital in Atlanta, Georgia. He specializes in bone marrow transplants for acute leukemia, myelodysplastic syndrome, myeloproliferative neoplasms, lymphoma, aplastic anemia, sickle cell disease, and the management of graft versus host disease. He's also an expert in CAR T-cell therapy, all of which makes him a busy guy. Please join me in welcoming Dr. Waller.
Great. Thank you. So I'm really pleased to be able to meet you all virtually and speak at the BMT Infinite Symposium of celebrating a second chance at life. And what we're going to talk today is about what to do when cancer comes back after a stem cell transplant or a CAR T-cell therapy. It's a broad topic, so I'll go over at somewhat of a high level, but I welcome questions from the audience about specific instances or any points you would like to have me clarify. I am going to advance my slides. All right. So I'm a professor at Emory. I've been here for about 3 decades. My clinical practice has been in managing patients mainly with hematological malignancies, with a stem cell transplant and CAR T-cell therapy. Although we've broadened our clinical focus recently to include patients with solid tumor malignancies, particularly germ cell cancer, and more recently some liver cancer, who are eligible for either stem cell transplant or CAR T. So I'll talk initially about the broad question of why cancer relapses. When you've been to so many doctors and you've gotten so many different types of therapies, why is cancer even still a question? And the bottom line is that cancer cells are not homogeneous. They're not all the same. Within a tumor, there are a small number of cancer stem cells that can survive chemotherapy and repopulate the tumor after treatment. And in the slide, you can see this idea with the cancer stem cells shown as red, admixed into a tumor that's comprised of other various cell types shown as green or blue. If a patient with cancer with this tumor gets the first treatment, the cancer shrinks and the volume of the tumor goes down, but you can see there's still a couple of red cancer stem cells which are resistant to chemotherapy. And after a second treatment, the tumor may shrink even more, but those cancer stem cells persist, and once treatment stops, they can cause the tumor to regrow. So the basic problem of cancer relapse is that we've not eradicated the very last tumor cell. And one can see the same concept in a different graphic, looking at the growth rate of tumor cells over days with the y-axis, the vertical axis, showing the number of cancer cells. And if you look on the left panel for no therapy, you can see that the tumor starts off with 1,000 cells and increases by 1,000-fold every 10 days. So from day 0 to day 10, it goes from 1,000 cells to 1,000,000 cells. From day 10 to day 20, it goes from 1,000,000 cells to 1,000,000,000 cells. And then from up to day 30, it would go to 10 to the 12th cells. Treating the cancer with one drug, in the next panel moving to the right, we can see that the growth rate of the tumor is decreased. In fact, the tumor volume on a log scale is decreased by 90%. So every treatment decreases the tumor volume by 90%. But once those 3 treatments stop, those 3 vertical red arrows representing the treatment, once they're stopped, the tumor regrows at the same rate. If we intensify the treatment by adding a second drug, shown in as the blue arrows, so every time we treat the cancer, we give the red drug and we give the blue drug in combination. Now we decrease the tumor volume by 99%. So we see a greater decrease in the size of the tumor, but again, after 3 treatments, there's still cancer stem cells surviving and the tumor regrows. Finally, on the right, if we further intensify the therapy by adding a third drug, the green drug, now we decrease the tumor by 99.9% every time we treat, so that by the end of 3 cycles of therapy, we've eliminated the very last cancer stem cell and the tumor is gone. So that's what we hope as oncologists to achieve, is complete eradication of the tumor. But often what we're faced with in reality when we see patients is more like the 2-drug example, that we put patients through lots of treatment, but there's still some surviving cancer cells that lead to relapse. Stem cell transplant was developed as a way of treating patients with leukemia, with lymphoma, and eradicating the very last cancer cell. And there's a difference between autologous stem cell transplants, where patients get their own stem cells, and allogeneic transplants, where patients get donor stem cells. And there's a difference in the incidence of relapse. In the auto-transplant setting, all the anti-cancer work is done by the intensity of the chemotherapy given before transplant. In contrast, in the allogeneic transplant, the donor T cells, the donor immune cells, can seek out and destroy cancer cells that may be relatively resistant to chemotherapy and survive the conditioning regimen. So you can think about it that the auto-transplant is like a 1-punch with your right hand, and the allo-transplant is a 1-2 punch that includes both the benefit of the conditioning regimen, the chemotherapy, as well as the activity of the donor T cells. And in this slide, we can see that the pre-transplant conditioning regimen in the chemotherapy we give before transplant varies in intensity. I've listed from a publication some years ago, I've listed all of the different usual regimens of chemotherapy that are given before transplant and ordered them according to their intensity. So busulfan, cyclophosphamide, TBI, at the very top part of this figure is the most intensive chemotherapy, and low-dose TBI at the very bottom is the least intensive chemotherapy. More chemotherapy is given with the hope of eradicating that last cancer stem cell, but it comes with the cost of increasing toxicity. Very low-dose TBI can be given as an outpatient. If you receive that type of treatment for a transplant and never got the stem cells, you would still survive. Your blood counts might go down for a few days, but they would bounce back to where they were before. And it's a well-tolerated and non-toxic therapy, but it is not as effective in eradicating the last cancer stem cell. So in general, as doctors, as oncologists, we try to give patients the most intensive regimen we think that they will be able to tolerate. And this is based upon results from a randomized clinical trial done from the Bone Marrow Transplant Cooperative Trials Network, whereby we randomized patients with AML or myelodysplastic syndrome to get either a more intensive regimen called MAC, myeloablative conditioning, or a less intensive conditioning regimen called RIC, reduced intensive conditioning, and then gave them the same transplant that they were programmed to receive, either stem cells from a brother or sister or from an unrelated donor. And in these data, published a couple of years ago, we see that the overall probability on the y-axis, the vertical axis, the probability of surviving without relapse is significantly higher in the group that received the MAC regimen, the solid black line, compared to the group that received the reduced intensity conditioning regimen, the dashed line. So more chemotherapy given before transplant leads to a higher probability of maintaining a relapse-free survival state. That high-dose chemotherapy, though, comes with the cost of increasing toxicity and indeed increasing non-relapse mortality. That yellow triangle in the middle of the slide is an increasing risk of the chemotherapy doing more harm than good. So there's a lot of clinical decision making when we take people to a stem cell transplant regarding how much chemotherapy to give before transplant. And that's a discussion typically that patients have with their doctor and picking the best regimen. So again, thinking about allo-transplant, and then we're going to talk about CAR T cells after this, but thinking about allo-transplant, whereby it's a 1-2 punch, chemotherapy to reduce the cancer stem cells, and then donor T cell immunotherapy to eliminate the cells that may be resistant to chemotherapy. There are multiple ways that leukemia cells can evade the immune system. One of which is they fail to express on their cell surface immune recognition molecules that are necessary for them to be seen by donor T cells. In addition, they can express extra molecules that incapacitate the ability of the immune system to attack them. They can produce soluble molecules called cytokines that also slow down the immune system or reduce the secretion of cytokines that accelerate the immune system. They can make enzymes that degrade the constituents, the amino acids necessary for the donor immune cells to function, or they can just grow too fast for the immune system to catch up. It's a very technical description, so I think we can think about leukemia cells as having a cloak of invisibility. They can become non-sticky, so they slip away from the immune cells. They can blend in so that the immune cells can't see them. They can hide in the dark, and they can grow too fast so that the immune cells can't catch up. These are all strategies that leukemia cells can use to evade immune surveillance after an allotransplant. So what do patients notice, and what do their families notice when when relapse might be a question? Well, their patients may have more fatigue, weight loss, night sweats, swollen lymph nodes, bone pain, or abnormal lab tests. And when they see their doctor, the doctor will examine them, looking for physical signs of cancer. Relapse may present with increasing lymph nodes under the neck or under the arms, but they may also do diagnostic tests. Many of you have had a bone marrow aspirate that's shown in the upper left panel with the metal needle going into the hip bone and the syringe drawing back bone marrow cells for analysis in the laboratory. Many of you may have had a PET scan, and I show a picture of a patient with a PET scan showing remission, no detectable cancer on the left, versus a patient with relapsed lymphoma, multiple lymph nodes lighting up on the PET scan on the right. And many of you may have your cancer followed by molecular tests. We can use the fact that cancer is a genetic disease, not inherited usually, but cancer cells have a different set of DNA molecules than a normal cell, and those differences can be detected by sophisticated testing involving PCR, polymerase chain reactions, or DNA sequencing, such that the doctor can detect very low levels of residual disease by these tests that anticipate clinical diagnosis of relapse. So by having testing done early on after transplant, we can determine whether patients might benefit from a strategy to prevent clinical relapse from occurring. And that strategy broadly is called maintenance therapy, something the doctor gives the patient to maintain the remission, to keep relapse from happening. Is there something we can do after stem cell transplant, after CAR T-cell therapy, to keep the patient in remission and prevent relapse? And this has turned out to be quite effective in a number of different disease diagnoses with a number of different types of transplant. This slide shows the benefit to lenalidomide maintenance for patients with multiple myeloma who underwent an autologous stem cell transplant. The upper curve shows a higher fraction of patients who remain progression-free with no detectable relapse who are randomized to receive lenalidomide or Revlimid versus the curve showing a lower frequency of patients who are alive without disease progression who are randomized to get placebo. Now, not every relapse in myeloma leads to immediate bad things happening, and indeed, overall survival of patients randomized to lenalidomide or randomized to placebo was the same. But we might anticipate, if we were to look at the survival curve for a longer period of time, not just 4 years, but 10 years, we would expect to see a survival benefit for patients who receive lenalidomide maintenance after stem cell transplant. In lymphoma, B-cell lymphoma and mantle cell lymphoma in particular, we see a benefit for patients who receive rituximab maintenance after an autologous stem cell transplant. The top panel with the red line shows the fraction of patients who were progression-free, randomized to receive rituximab for a diagnosis of mantle cell lymphoma versus the blue curve showing the fraction of patients without disease progression or relapse randomized to observation. Again, the overall survival is not as distinct, but we see that the remission status, the staying alive without relapse, was superior from 45% risk of relapse disease progression for patients who got observation decreased to 20% for those patients who got rituximab. So again, a maintenance strategy to keep patients in remission. And here is data for an allogeneic transplant setting. These are patients with AML whose AML had a particular mutation called FLT3. FLT3 is a gene that's often mutated in AML and makes leukemia cells grow faster. We have a drug to selectively inhibit the enzymatic activity of the FLT3 gene, and that drug is called gilteritinib. So we participated in a randomized clinical trial for patients with FLT3 positive AML undergoing allogeneic transplant and randomized patients to receive the maintenance drug gilteritinib versus placebo drug. The initiation of therapy was about 2 months after the transplant when the patients all still were in remission. And you can see on the left, the blue curve is significantly higher than the red curve. So more patients stayed alive without evidence of leukemia relapse if they got maintenance gilteritinib versus the red curve. That's good. So if patients have some low-level detectable disease called MRD positivity, they had a clear benefit from getting maintenance gilteritinib. On the right, you can see what happens if they had no detectable disease. They were MRD negative, meaning the PCR test couldn't find any evidence of leukemia in their blood after the stem cell transplant. Here you see there's no difference in relapse-free survival if they got gilteritinib or placebo. So this tells us that the idea of maintenance should be driven by really knowing what the disease status of the patient is. Maintenance, it carries with it some of its own potential toxicities, so we want to reserve it for the patients who will benefit from it the greatest, and those are patients who have detectable disease below what would be called a clinical relapse, but still detectable using these very sophisticated molecular tests. We can also use immunotherapy to treat relapse. CAR T cells are commonly used, and I see a number of you have questions about CAR T cells. They can treat a relapse of leukemia or lymphoma that's occurred after either an autologous or an allogeneic transplant. Immune checkpoint blockade therapy, antibodies to reactivate T cells have been used with relapse after allotransplant, but they may cause very severe graft versus host disease. Commonly used approaches include hypomethylating drug therapies like azacitidine or decitabine that may make the leukemia cell more susceptible to being recognized by the immune system, stripping away some of those shielding strategies that I showed you earlier that makes the leukemia cell invisible to the immune system. The hypomethylating drug therapy can shine a light on the leukemia cells so the T cells can seek them out and destroy them. And in some cases, we may give additional donor immune cells or a second transplant if patients have relapsed after an initial allogeneic transplant. So let's talk a bit about CAR T cell therapy. CAR T cells are clearly a breakthrough for patients with relapsed lymphoma or multiple myeloma. These are FDA-approved products that use patients' own lymphocytes to manufacture a population of cancer-targeted killer T cells. And this slide shows the evolution of CAR T cells over time. We've made them more effective by making them a little bit more complex. This is showing the first generation, second generation, and third generation of CAR T cells. And I won't try to teach you all about which co-signaling domain is more effective, but simply to say that many people around the world have worked hard to understand how to engineer T cells to be more effective in fighting lymphoma and fighting myeloma. And the end result is by tuning the molecules, the new molecules that are expressed on the T cell called the chimeric antigen receptor, or CAR, by tuning that molecule with specific DNA sequences, we can create a CAR T cell that expands 1,000, maybe 1 million-fold in the patient and can eradicate disease. It's a complex process that some of you have gone through, so you'll recognize the different steps. First, we have to harvest normal lymphocytes from the blood of the patient or a volunteer donor, select the cells that are going to be used for CAR T cell manufacturing. This often involves purifying the T cells, in some cases purifying NK cells, and then genetically modifying them. So we want to insert into the T cell or the NK cell a new piece of DNA that will reside permanently within the cell nucleus and instruct the cell to express on its cell surface that CAR. I'm going back a slide to show you the green structure, which is outside the cell. That's the recognition molecule the CAR uses to identify the tumor cell. Once those T cells have been manufactured over a week or 2-week time period, they're packaged up in a bag, frozen, and then shipped back to the hospital, whereby they're infused into the patient after the patient has received a sequence of drugs to deplete their own lymphocytes, creating new space for the CAR T cells to grow. And then those CAR T cells home to the disease sites and eradicate the cancer. This approach has been very effective in certain diseases, initially in pediatric acute lymphoblastic leukemia, a study that led to the FDA approval of the first CAR T cell product, whereby most of the recipients were children, median age of 11. Most of them had had prior allogeneic transplant and had relapsed, and many of them had had 2 or more relapses, and most of them had detectable leukemia at the time of CAR T cell infusion. The adult patients in this particular study were older, had not had allogeneic transplant, and most of them had primary refractory disease that had not responded to any therapy. You can see from the figure on the right that half of these patients, heavily pretreated, some truly at death's door, were long-term survivors after a CAR T cell infusion. This same product called Kymriah or Tisacel was used to treat lymphoma patients. We participated in the lymphoma study at Emory, and you can see that among all patients, about 40% were long-term survivors without recurrent lymphoma, and if they had initial response of their lymphoma to the CAR T cell infusion, 2/3 of them remained lymphoma-free at 2 years. This therapy was really life-changing for the patients and revolutionary from our perspective as doctors. But it still is not able to eradicate the cancer from everybody. And again, half the patients or more were not cured with CAR T cell therapy. This is one of our patients at Emory who received Tisacel or Kymriah for lymphoma. You can see the lymphoma is in the black areas, highlighted by the red bars. You can see in the groin that very large black circle all represents lymphoma growing in the patient before they receive the CAR T cell infusion. 6 months later on the right, that black circle is gone. The remaining black areas on the PET scan represent the bladder and the heart, which are normal. And if you have very good eyes, you actually can see the vocal cords lighting up as 2 little black wings right below the chin that are metabolically active because the patient was talking. So clearly, CAR T cells can offer curative therapy for patients, even with significant bulk disease. There are 3 different brands of CAR T cells for lymphoma: Lysocell, Axicell, and Tisacel. They've been compared to each other in retrospective studies, and it appears that Axicell and Tisacel are more effective in lymphoma patients than Axicell and Lysocell are more effective than Tisacel. So the specific constructs of the CAR, the DNA sequences that are used to modify the T cell, make a difference in terms of how effective the CAR will be in eradicating disease. Both Axicell and Lysocell are more effective than auto-transplant for patients with relapsed lymphoma. So patients with diffuse large B-cell lymphoma typically receive a chemotherapy regimen called CHOP, or R-CHOP, that is a combination of an antibody, rituximab, and 4 different chemotherapy drugs given every 2 or 3 weeks. If patients relapse after R-CHOP, our standard of therapy was to go to a high-dose chemotherapy and stem cell transplant, called standard of care, or SOC, on the slide. When patients with that relapsed disease were randomized to receive either CAR T or standard of care therapy, the progression-free survival was clearly superior for those patients randomized to the CAR T. So CAR T cells have replaced autologous transplant for most patients with relapsed lymphoma. In a similar vein, CAR T cells to target myeloma are superior to standard of care for patients with relapsed myeloma. On the left, you can see cilta-cel compared to standard of care. On the right, you can see ide-cel compared to standard of care. And in particular, cilta-cel, or Carvykti, is able to produce long-term remissions in over half of the patients with relapsed myeloma, so that we think some of those patients will be cured because they're receiving a CAR T cell that selectively attacks their myeloma. ALL is another area of great interest for CAR T cells. In adult patients, obe-cel is able to produce durable remissions in more than 40% of patients, and these CAR T cells persist in the blood to a greater extent than the initial Kymriah CAR T cell product did, with low toxicity. So by improving the design of CAR T cells, the specific DNA sequences which are introduced into the T cell, we hope to continue to improve the efficacy of CAR T cells. Well, that's great if you stay in remission, but what do we do for those patients who relapsed after CAR T cell therapy? What are their options? Well, there are a number of different therapies that may be effective for myeloma or lymphoma patients who've relapsed after CAR T. Bispecific antibodies can reactivate the T cells in the patient's blood. A second transplant could be performed. You just start over with a new donor graft, hopefully to use the donor T cells to eliminate residual disease. Or sometimes patients can receive a second infusion of CAR T cells that targets a different lymphoma or myeloma specific antigen. This shows the survival of patients who received a bispecific antibody in red or blue curves at the top of the slide, compared to patients who received another standard of care therapy for disease relapsed after CAR T. And these are lymphoma patients who received, in the red curve, who had relapsed late and received bispecific antibody, and in the yellow curve, patients who with relapsed disease late who received standard of care therapy. So getting a bispecific antibody was particularly effective if patients had had a late relapse of their disease after their initial therapy. Allo-transplant can also salvage about a third of patients with lymphoma that's relapsed after CAR T cell therapy. On the left, we see overall survival stabilizing at about 1/3 of patients who received allo-transplant for relapsed lymphoma. On the right, we can see that this comes with some cost. Non-relapse mortality occurred in 25% of patients, and progressive lymphoma growth, relapse disease progression, occurred in 40% of patients. So we're still have more work to do to improve the management of patients whose disease has relapsed after CAR T. Relapsing later, in this case, is better than relapsing earlier. relapsed disease, relapsed lymphoma, more than 3 months after CAR T-cell infusion, patients had much better survival than patients whose disease relapsed very early. The red curve is superior survival compared to the early relapse blue curve. And a second CAR T may also be used. So this is a somewhat complex slide, but it tells us that a third of patients who don't respond to initial CAR T may achieve a durable remission by getting a second CAR T-cell infusion, particularly if it's targeting a different antigen. Well, what about relapsed after allogeneic transplant? We talked about how different strategies can be used to manage relapses after CAR T. What about relapses after an allogeneic bone marrow transplant? Well, we can flip the sequence of therapies, so we can give a CAR T for certain diseases that have relapsed after an allogeneic transplant, particularly in the setting of B-cell acute lymphoblastic leukemia. We can also perform a second transplant, a second allogeneic bone marrow transplant for patients with a late relapse, or give hypomethylating drug therapy for patients with minimal detectable residual leukemia or myelodysplastic syndrome following allogeneic transplant. So we'll go through some of these strategies. This shows, and you may recognize this figure because I showed it earlier, it's the data from the trial that led to FDA approval of Tisacel or Kymriah for acute lymphoblastic leukemia. And it makes the point that nearly 3/4 of the pediatric patients who received this therapy had relapsed after allogeneic transplant. So it still can offer curative therapy. Second allotransplant can be used for patients with myeloma. It's not very effective for patients with an early relapse, but it can prolong survival and cure about 1/4 of the patients for those patients who've had a late relapse of their disease after an allogeneic transplant. Hypomethylating drug therapy can reawaken the ability of immune cells to see leukemia, and that can improve survival for patients with relapsed AML after allotransplant, and giving additional donor lymphocytes is often used in this setting. Hypomethylating drug therapy increases the activity of the donor T cells. We can see on this slide the percentage of T cells in the blood that are donor origin goes up when we give hypomethylating drug therapy, and that increasing frequency of donor T cells implies more ability of those cells to attack leukemia. Second transplant or donor lymphocyte infusion is most effective, again, when the disease burden is low. Patients with a low blast count of less than 5% in the red curve have better survival than patients whose bone marrow has greater than 5% blasts in the blue curve. So we've talked a lot about different chemotherapy strategies and cell strategies. What about the human aspects of this? What can patients do? What can families do to help manage relapse? Well, diet is important. We know that a diet that promotes a diverse microbiome in the intestines, the gut microbiome, has been associated with less gut inflammation and better anti-cancer immunity. So many patients ask me, what diet should I eat? I always tell them to eat a varied diet with lots of different fiber and nuts, because that may help their immune system fight cancer. Psychological stress may increase inflammation and impede the success of donor T cells, so managing stress is also important. Fear is a big issue for patients with cancer who've gone through CAR T or stem cell transplant. We know that the fear of relapse is inevitable, and there's a limit to what we can do as doctors or what patients can do to prevent relapse. Some of it is really beyond our control to manage. So I advise patients to try to enjoy to the greatest extent the days that they have where they're well, recognizing that they don't know what will happen in the future, and indeed they can't control it, and not to rely on scans or marrow biopsies to have hope. Hope should always be available to patients, and we don't need to wait for a good scan result to be optimistic. Family and support are important. Nutrition, exercise, stress management, all can be combined to improve patients' emotional state, physical state, and even the ability of their immune system to fight cancer. And caregivers are important. They provide emotional, practical support. They can help discuss test results with the doctors and ask, well, what if plan A doesn't work, what will plan B be? What are the options if the disease does relapse? Patients and families are encouraged to seek a second opinion at a center that may have a higher volume of patients or that may have available a clinical trial which offers a new therapy that might be more effective than existing therapies. Fear of relapse is also stressful for caregivers, so I advise family members to seek out support as well. So I'll end and summarize with a couple of takeaway messages. An ounce of prevention is worth a pound of cure. The more the doctor can control and reduce the disease before patients undergo a stem cell transplant or CAR T-cell therapy, the less the risk of relapse, and maintenance therapy, targeted maintenance therapy after transplant, and most likely after CAR T-cells as well, may help prevent relapse. CAR T-cells are more effective than auto-transplant for relapsed lymphoma, and CAR T-cells can be given after allo-transplant and still cure up to half of patients with relapsed B-cell lymphoblastic leukemia. Allo-transplant can then also be given after CAR T-cell and cure another third of patients. So even though these therapies are intensive, they may be given in sequence in the appropriate setting to eradicate disease that has relapsed after initial cell therapy. So I'll end there on time for some questions from the audience, and I'd be happy to answer those as they're made available to me.
Thank you, Dr. Waller, for this excellent presentation. We will now begin the question and answer session. If you have a question for Dr. Waller, please use the chat box on the left side of the screen to submit your question. We'll answer as many questions as possible. Our first question is, what is the current relapse time for MCL? I had standard care treatment from Hopkins in 2021, followed by a stem cell transplant, then only 4 rounds of rituximab maintenance due to many fevers of unknown origin and other issues. I was supposed to be on it for 3 years.
So mantle cell lymphoma is also heterogeneous. Some types of mantle cell lymphoma grow very quickly. Some may be more indolent. We believe that there's a fraction of mantle cell lymphoma patients who can be cured by transplant and by maintenance therapy. And if I skip quickly to the slide that I showed earlier on mantle cell lymphoma, you can see that on the group that got rituximab, there we go. The group that got rituximab up to 6 years, 3/4 of those patients remain in remission. So while disease relapse may occur late, I congratulate you if your disease is still in remission, and I would be optimistic that it stays in remission. The good news for mantle cell lymphoma is even disease which has relapsed after a stem cell transplant can be effectively treated with a lot of different strategies. Bruton's tyrosine kinase inhibitors are very effective for mantle cell lymphoma, as are a variety of CAR T cells. Next
Thank
question.
you for that. Yes. Are cancer stem cells particularly dependent on glucose for growth, and therefore a ketogenic diet that minimizes glucose and insulin might be beneficial?
That's an area of active investigation. Cancer stem cells have long been known to utilize glucose as their primary energy source. There's no clear evidence from randomized clinical trials that a ketogenic diet is going to have a major effect, in part because even with a ketogenic diet, the level of glucose in the blood stays in a normal range. It's not as if you can survive with no glucose at all, because the brain needs glucose the brain cells have to have glucose to stay alive. But certainly I advise patients that having a diet which is relatively free of refined carbohydrates and relatively rich in vegetables and nuts makes sense from a general health perspective, and I believe makes sense from a cancer perspective.
Thank you for that. How long do AML patients have to stay on Zospata after transplant?
So maintenance therapy is usually measured in years as maintenance. It can be monitored by PCR tests. Sometimes we stop early if patients remain PCR negative and they have toxicities from the maintenance therapy. So that question really is something to discuss with your doctor.
Next question is, how do CAR T cells become cancerous cells in some cases?
So manufacturing CAR T cells involves inserting new pieces of DNA into an existing T cell. Occasionally, rarely, there is a abnormal T cell in the blood during CAR T cell manufacturing that when the new DNA is inserted into that cell's nucleus, it can create a new lymphoma cell. That happens quite infrequently at a low rate, and in my opinion should not dissuade patients or doctors from prescribing CAR T cells, because the number of cases in which that's occurred of the tens of thousands of people who receive CAR T cells is less than a dozen. But it's still something to be aware of as a potential side effect and risk.
Thank you for that. The next person wants to know, what are your thoughts on intermittent fasting after CAR T therapy? Is there a way to metabolically reset?
Again, it's an interesting idea. Intermittent fasting, I have to tell you, my wife does that and sometimes makes me miss a meal or two. It certainly is a great way to lose weight. It's unclear whether it will have a significant long-term benefit for patients who received CAR T cell therapy. As long as your weight is staying in a normal range, I don't believe it's dangerous, but I would let your doctor know that you're doing that, because intermittent fasting can cause some abnormalities in routine blood tests that your doctor might be puzzled if he or she is not aware that you're fasting.
Okay. Next person would like to know, what role does psychological stress play in cancer cells? Does this increase the chance of recurrence?
So psychological stress does affect the immune system, and we know the immune system is important in many cases in controlling cancer cell. I think life is better with experiencing less stress, so I think strategies to manage stress are advised for cancer patients as well as everyone. But I don't think that patients should feel responsible that they did something wrong if their cancer recurs. We don't have a clear signal as to what level of stress might increase the risk of relapse, and we certainly can't point to patients as being responsible for their relapse if they were not able to manage stress effectively. I can tell you from personal experience, all of my working day, there's a lot of stress. I mean, dealing with phone calls, dealing with sick patients, dealing with insurance company denials. Stress is a fact of life, so that it's not a question of eliminating stress, it's a question of managing stress to enjoy one's life to the greatest extent possible.
Good point. Next question is, do menin inhibitors figure in your thinking about relapse treatment?
Menin inhibitors are really exciting drugs that can be used both for ALL and AML and should be considered as maintenance in this setting. Absolutely.
Okay. How long on average do CAR T cells remain active after initial infusion?
So that's an interesting question. It varies by the brand of CAR T cells. One of those earlier slides I showed that indicated first generation, second generation, third generation. The inside the cell part of the CAR T helps determine how long it remains active. For axi-cell, CAR T cells remain active for months. For lysocell or tisocell, CAR T cells may remain active for years, to the extent that patients who received tisocell or Kymriah may not have recovery of normal B cells. Emily Whitehead, the first pediatric patient treated with CAR T cell therapy more than 10 years ago, is still alive with no detectable leukemia, but also no normal B cells, because there's enough CAR T cells still in her system to eliminate the B cells in her bone marrow. So she needs to get immunoglobulin infusions every month or so. And I have patients in my clinic, not 10 years out, but 6 years out from CAR T cells for lymphoma, who still have sufficient CAR T cells in their body to prevent normal B cells from recovering. So it varies a lot by the brand of CAR T cell, and it varies a lot from patient to patient.
Okay. Next question is, how long should I continue maintenance in high-risk FLT3 NPM1 plus AML? I had early relapse after the first transplant and underwent a second one 11 months later.
I mean, the studies have looked at maintenance for 2 years. I think it's a discussion, if you've relapsed after initial therapy, to have with your doctor. If you're getting a FLT3 inhibitor and you're tolerating it well, I would repeat these highly sensitive PCR tests. And in my practice, I would certainly treat probably for 3 years to give a little margin of extra drug exposure, and maybe longer if relapse had already occurred from a prior transplant.
Okay, looks like we have time for just 2 more questions. The next one is, for multiple myeloma, if the relapse comes 5 to 6 years after transplant, would a patient normally move to CAR T or a second transplant? What are the criteria for deciding the course of treatment?
So I think that's been a question addressed by prospective clinical trials that haven't, the results are not finalized, but I think the activity of CAR T cells is quite striking, particularly Carvykti. Transplant sometimes can be used to debulk the disease, and both therapies may be given in tandem to achieve optimal disease control.
Okay. And our final question, if a patient receives an allogeneic transplant and then relapses, would you suggest a CAR T from the donor's T cells instead of the patient's?
So typically in that setting, we have used the patient as the source for the CAR T, recognizing that they are engrafted with donor T cells. It's been difficult to collect the donor separately from the patient for CAR T cell manufacturing, given the insurance approval for CAR. The process of getting insurance approval for CAR T typically specifies that we collect the cells from the patient with cancer. Those T cells are donor-derived, and in my experience can be quite potent in their anti-leukemic activity, even in patients with relapsed disease. I think collecting and manufacturing CAR T cells from the donor directly is of interest, but would probably need to be done in a clinical trial.
Okay. Unfortunately, we are out of time, but on behalf of BMT Infinite and our partners, I'd like to thank Dr. Waller for a very helpful presentation, and also thank the audience for your questions. Please contact BMT Infinite if we can help you in any way, and enjoy the rest of your day.